Hi everyone. Today in this video we are going to discuss about important concepts of anti-tubercular agents. In our previous video we have already discussed few of the key points of anti-tubercular agents. So this is the second part of our video series and here we continue with the further key points in question and answer format. Sixth one. Select the drug that can produce red discoloration of the skin. Options are A. Capreomycin, B. Rifampin, C. Dapsone, D. Clofazimine. So which type of drug produces the red discoloration of the skin? The right answer is clofazimine. Clofazimine by nature it is a brick red colored dye, and when this drug is used it can produce some red discoloration of the skin as well as urine. But this drug is particularly used to treat the leprosy as an anti-leproral agent. Then how it is useful in the tuberculosis? Normally tuberculosis is treated by first line and second line agents, but whenever these drugs are getting the resistance resulting in the extended drug resistant tuberculosis, in such case clofazimine can be added, but because this drug is a dye, it can produce some red skin pigmentation. Similarly, other drugs like the capreomycin. Capreomycin is an aminoglycoside antibiotic which can produce some ototoxicity, and rifampin is one of the drug. It can produce some orange color to saliva and urine, but this is not the discoloration, only it produces a small change in the color shade because this rifampin is going to be distributed into the saliva, urine and other body secretions. So it can produce some orange color to these body fluids. And finally, dapsone is one of a sulfone which can produce a hemolytic anemia and is not producing any side effect related with the color change. So here the right answer is the clofazimine which produces the red pigmentation of the skin. Seventh one. Which of the following drug is more effective in multi-drug resistant tuberculosis, commonly known as XDR-TB? So in case of multi-drug resistant tuberculosis, which type of drug is more effective? Options are A. Kanamycin, B. Moxifloxacin, C. Cycloserine, D. Ethionomide. So here what is the right answer? The right answer is moxifloxacin. Here what are the drugs listed out? All these are the second line agents which are used when the first line agents are getting resistance. But among these agents, again, few of the drugs are getting resistance in the tuberculosis. For example, kanamycin is an aminoglycoside antibiotic. So suppose if the tuberculosis strain is going to get the resistance towards the streptomycin, which is again the aminoglycoside antibiotic, the same resistance can also be observed with the kanamycin. So aminoglycosides can get the resistance and these drugs show the cross resistance. Therefore, they are somewhat less effective in the multi-drug resistant tuberculosis. On the other hand, moxifloxacin is a fluoroquinolone, particularly it is a 4th generation fluoroquinolone which is highly effective towards the multi-drug resistant tuberculosis. And other drugs like the cycloserine and ethionomide, both are the bacteriostatic drugs which are somewhat less effective in MDR-TB. So fluoroquinolones are highly effective against the multi-drug resistant tuberculosis. So not only moxifloxacin, levofloxacin is also useful. 3rd and 4th generation fluoroquinolones are more effective towards the MDR-TB. Eighth one. Which of the following drugs shows variable pharmacokinetics in different population? A. Rifampin, B. Isoniazid, C. Rifabutin, D. Clofazimine. So which drug shows a variable pharmacokinetics in the different population? The right answer is isoniazid. Isoniazid is the first line agent for the treatment of tuberculosis, and this drug can undergo metabolism such that it produces the N-acetyl isoniazid by N-acetylation. So this acetylation is one of the key metabolic pathway for the isoniazid, but few of the people can act as slow acetylators, but another group of people can act as fast acetylators. So in the slow acetylators, isoniazid undergoes less metabolism, so it will have more duration of action. But in the fast acetylators, it is immediately metabolized, so it will have short duration of action. In this way, it shows different pharmacokinetics in the different population because of the acetylation capacity of metabolic enzymes. Ninth one. All of the following drugs can induce hypothyroidism except A. lithium, B. para-aminosalicylic acid, C. kanamycin, D. imidazole. So here all the drugs produce hypothyroidism except, so here which drug is not producing the hypothyroidism? So the right answer is kanamycin. Remaining 3 drugs can produce the hypothyroidism. So lithium is one of the antimanic agent which can produce the hypothyroidism. Similarly, para-aminosalicylic acid is the second line agent used in the treatment of tuberculosis which can produce again hypothyroidism as well as hepatotoxicity. And kanamycin is one of the aminoglycoside antibiotic which mainly produce ototoxicity and nephrotoxicity. So it is not affecting the thyroid levels. Finally, imidazole is one of the class 3 antiarrhythmic agent and this drug is having the iodine moiety within the structure, so it can produce the thyroid abnormalities such that it can produce either hypo or hyperthyroidism. So here lithium, para-aminosalicylic acid and imidazole, all these drugs can induce the hypothyroidism, but kanamycin is not affecting the thyroid levels. 10th one. Which of the following drug may produce gout in susceptible patients? A. ethionamide, B. capreomycin, C. isoniazid and D. pyrazinamide. So what is the right answer? So which type of drug can increase the uric acid levels, thereby it can induce the gout? The right answer is pyrazinamide. Pyrazinamide is the first line agent for the treatment of tuberculosis and this drug can inhibit the uric acid excretion, thereby it can increase the hyperuricemia resulting in the gout in the susceptible patients. Similarly, we have another drug like ethambutol. Ethambutol can also inhibit the uric acid excretion, thereby it can also increase the risk of gout in the patients. So whenever this pyrazinamide and ethambutol are combinedly given, there is an increased risk of gout in the susceptible patients. That's why these two drugs are included in the initiation therapy for 2 months along with the isoniazid and rifampicin. But for the continuation therapy for the next 4 months, pyrazinamide and ethambutol are excluded to eliminate the risk of gout in the patients. 11th one. All of the following are enzyme inducers except A. rifampin, B. phenytoin, C. isoniazid, D. carbamazepine. So here many of the drugs are metabolic enzyme inducers except one of the drug. So what it is? The right answer is isoniazid. Isoniazid is actually an enzyme inhibitor. This drug is going to inhibit one of the enzyme CYP2C19 and because of this it can inhibit the metabolism of the other drugs resulting in their increased levels within the plasma. For example, isoniazid can increase the levels of phenytoin because it inhibits its metabolism. Similarly, isoniazid can also inhibit the metabolism of carbamazepine, thereby it can increase the levels of carbamazepine. In this way, isoniazid is an enzyme inhibitor. It can affect the other drugs like phenytoin, carbamazepine, acetaminophen, valproate, ketoconazole. In this way, so many types of drugs are affected by isoniazid. On the other hand, other drugs listed here like rifampin, phenytoin, carbamazepine, all these are enzyme inducers. 12th one. Which of the following drug can be added in extended drug resistant tuberculosis? Options are A. kanamycin, B. linezolid, C. rifabutin, D. levofloxacin. So which drug is added in the extended drug resistant tuberculosis? The right answer is linezolid. Even it is not approved by the FDA, linezolid and another drug clofazimine, both of these drugs are effective against the extended drug resistant tuberculosis. What is this extended drug resistant tuberculosis, commonly known as XDR-TB? This XDR-TB is one of the resistant strain which shows resistance towards the first line agents like the isoniazid and rifampin. Normally, whenever resistance is developed towards these first line agents, it is called as multi-drug resistant tuberculosis, where we can use the fluoroquinolones, which are the better agents to control the multi-drug resistant tuberculosis. But when this resistance is going to be extended to the other antibiotics like amikacin and capreomycin, which are the aminoglycoside antibiotics. Similarly, resistance is extended towards the fluoroquinolones. Then it is called as extended drug-resistant tuberculosis. In such case, we can use few of the drugs like the linezolid and clofazimine, which are somewhat more effective compared with the fluoroquinolones. So that's about the different key points in the anti-tubercular agents. Hope you have enjoyed this video. If you like this video, please subscribe to our channel, share this video with your friends, post your comments in the comment box. Thank you for watching this video.